Hello everyone. So today we're going to talk about junctional rhythms. So if you grab that PowerPoint, I made this one on my own. The book did not provide one. So with a junctional escape rhythm, it occurs when the electrical activation of the heart originates near or within the AV node rather than from the SA node. So with junctional escape rhythms, what you will see is the abnormal P wave. It can be absent as well as inverted or upside down, or also it could be slightly after the QRS. Typically with this rhythm, you have a normal QRS. It usually occurs after a pause. In the junctional escape rhythm, the heart rate is typically between 40 to 60 beats per minute. So if you look at the rhythm strip next to the description, you see where it says sinus beat failed to materialize. You have the arrow. There's no P wave there. If you look at the next complex, you'll see that there's no P wave there as well. And here's an example of another junctional escape rhythm. And as you can see, both on each complex, the first, the second, the third, and the fourth, they're all inverted. So what are some causes? If you're talking about medications, it could be due to beta blockers, calcium channel blockers, DIG. It could be from problems within the heart itself, from rheumatic heart disease, could be due to a valve. Treatment is just depends on the underlying cause. With an accelerated junctional rhythm, the AV junction speeds up and it fires at a rate of greater than 60 beats per minute. So with junctional, you want to make sure you write down junctional escape rhythm 40 to 60, accelerated greater than 60. Typically that ranges between 60 to 100. So with this, again, you're going to see your abnormal P waves. They could be absent, inverted, and typically you have a narrow QRS as well. So if you turn the page here, and if you would you look at your, let's say we do the second and third complex, the way you would find the rate, because obviously this looks like a regular rhythm, you would do 1500 divided by the number of small squares. That's how you get your rate. So some causes of this, typically you can see this in COPD, hypokalemia. Often the patient is asymptomatic. The next picture shows an accelerated junctional rhythm. So with this one, as you see, it looks like the P waves, as you notice, that's the first thing that tips you off, is the P waves are not normal with this rhythm. So with junctional tachycardia, typically you have a rate between 101 to 440 beats per minute. And with this, the impulse originates lower in the junction, typically in the bundle of His. So again, first thing I always look at is the P wave. So with junctional tachycardia is absent, inverted, normal QRS. Some causes of a junctional tachycardia, possibly heart failure, ditch toxicity. Patients can become symptomatic with this. They may complain that their heart is racing. Maybe they're anxious. The myocardial oxygen demand increases. So treatment of this, you could do the vagal maneuver with your patient. Adenosine, that can help distinguish between a junctional tachycardia versus a SVT, supraventricular tachyarrhythmia, which you'll learn about. So then there's a few other rhythms that I just attached to this PowerPoint. So you could look at the rate and figure out what rhythm it is. So moving on to ventricular rhythms, heart blocks. So we talked about PACs. Now we're going to discuss PVCs, which are premature ventricular contractions. So the impulses arise from an irritable site within the ventricle. It occurs early, and if you look at the QRS complex, it looks very bizarre. It's usually wider than greater than 0.112 seconds. Also, the subsequent T wave is usually in the opposite direction. You also have the absent P wave. It's followed by a compensatory pause because the SA node is not affected and it has not taken time to reset. So if you look at the picture left to the description, you can see the PVCs. And if you look at this, you have a PVC pretty much with every other beat. So when describing PVCs, PVCs that look the same, they're called unifocal. So if you look at the photo to the right-hand side, you can see the two PVCs there. They're both the same, as well as below. PVCs that look different are called multifocal. So if you look in the second picture there, you'll see one PVC is upright where the other is upside down, and that's multifocal. When you have a run of 3 or more PVCs in a row, it's typically called a salvo. And this often precipitates VTAC or VFib. Both are deadly rhythms. So when you have a PVC that's every second beat here, that's known as ventricular bigeminy. Ventricular trigeminy is every third beat there is a PVC. So PVCs, they can often be harmless in patients. They can be associated with caffeine, alcohol, nicotine, anything that speeds up that heart rate. They're not harmful with a normal heart, but someone who has heart disease can have frequent PVCs, and these can reduce cardiac output and lead to angina. So when my mother was having chest pain when she was mowing the grass a couple summers ago, she had chest pain, she went to the ER, and she was throwing very frequent PVCs. And of course, you know, when you have angina, you have PVCs, you know, you want to think about blockage in the coronary arteries. But like I said, normal people who don't have a diseased heart, it's harmless in them. Next, moving on to ventricular tachycardia. So when you have, this is a run of greater than or equal to 3 PVCs. So monomorphic, that means the QRS complexes look the same. Polymorphic, each QRS complex can look different. VTAC can be sustained or it can be non-sustained, where maybe the patient is in normal sinus rhythm. they have a run of V-tach, then they go back to a normal sinus rhythm. So the ventricular heart rate can be anywhere from 150 to 250. The rhythm, it can be regular or irregular. Obviously, the P waves, they're absent or they're buried in the QRS complex, and the PR interval, clearly that is not measurable. So some clinical associations of V-tach you see there to the left side. It can be caused by a long QT syndrome. And you think about some medications that can cause that. One antibiotic that you have to watch out for is Zithromax. So clinical significance, V-tach, it can be stable or unstable. So if, let's say, for instance, maybe you're working on a general floor, the telemetry tech calls up to the floor and says, your patient's in V-tach. So the first thing you want to go do is check your patient. Do they have a pulse? If your patient's in V-tach, they have a pulse, that's considered to be stable. If they call up patients in V-tach, you go check the patient, there's no pulse. That's considered to be unstable. And clearly, you're going to call a stat page overhead, and you want to defibrillate right away because you want to stop the heart so the impulse goes back to the SA node. So some reasons why or causes that you have sustained V-tach, obviously cardiopulmonary arrest, there's decreased blood flow to the brain, pulmonary edema, hypotension. So when you're looking at, if you turn the page, ventricular tachycardia treatment. So if you looked at the 6-second strip below, you can tell that that is monomorphic V-tach. All of the QRS complexes, they're symmetrical, they all look the same. As well, each ventricular impulse is being generated from the same place in the ventricles. So if a patient, is in V-tach, they have a pulse, they're stable. Things that you may want to think about giving: IV procainamide, amiodarone, lidocaine. With polymorphic V-tach, and if you look below, you can see where each QRS complexes here, they vary. They look different. So the QRS complexes, they're not symmetrical. And this is because the ventricular impulse, it can be generated from a different location. So V-tach without a pulse, again, this is a life-threatening situation. You need to call the stat page, begin CPR. Someone needs to get that defibrillator machine to the room ASAP. Other things that can be done is ablation if a patient has repeated episodes of V-tach. The next rhythm is torsades de pointes. It's referred to as French for twisting of the points. And if you're looking this type of V-tach here, obviously the QRS complexes are very different, so it makes it polymorphic. And this is associated with a prolonged QT interval. With V-fib, and if you look at this, you see the rhythm there. It can be associated with a myocardial infarction. It results from chaotic firing of multiple sites in the ventricles. So it causes the heart muscle to quiver rather than contract efficiently, producing a muscular contraction. And essentially here, there is no cardiac output. So with V-fib, typically if you're working on the floor, someone calls up, and the telemetry text says patient's in VFib. Well, you as a nurse, you don't want to go take the time to go find the patient's nurse. So if you're answering that phone and that patient's in VFib, you need to go run to that room and check that patient because, they're probably unresponsive. They don't have a pulse. They could be having apnea. So you want to call a stat page right away, begin CPR, once someone gets the defibrillator monitor there. Drugs that can be used are such as epinephrine. So defib, it's most effective method of terminating VFib and pulseless VTAC, and that's something that you need to know. So passage of an electrical shock through the heart depolarizes the cells of the myocardium. Again, it allows the SA node to take over the role of the pacemaker of the heart. So with defibrillation, it's measured in joules or watts. You have biphasic defibrillators. This is first and successive shocks of 150 to 200. And the shock is going actually in two different directions. One wave is moving down where the other is moving upwards. Monophasic, it's moving in one direction, and the initial shock is typically 360. If you turn the next page, you'll see what is called a idioventricular rhythm. And a lot of students mix this up with third-degree heart block. So third-degree heart block looks very similar to this. The difference is with third-degree heart block is that you will see P waves. With idioventricular rhythm, there is no P wave. And so it's a very slow heart rate between 20 and 40. You'll notice you have those very wide complexes. The impulse is originating from the Purkinje fibers. And again, there's no P wave, there's no PR interval to measure. So this can be caused by acute coronary syndrome, ditch toxicity. Treatment of this, atropine, that can increase your heart rate. Often patients, they may need a pacemaker. So with AV blocks, this can be a partial delay or complete interruption in the cardiac conduction pathway between the atria and the ventricles. So there are several types of heart block. So you have a first degree heart block, second degree heart block type 1, that's also referred to as Winky block, second degree heart block type 2, known as a Mobitz, third degree heart block. I always say second degree heart block type 1 or second degree heart block type 2. I try not to use the term Winky block or Mobitz because if you use too many terms, then obviously that's going to confuse you. So with first degree heart block, essentially you need to know your normal PR interval, which is 0.12 to 0.20 seconds. So with this, you're going to be measuring your PR interval. And so if it's greater than 0.20 seconds, then the patient is in first degree heart block. And the prolonged PR interval is typically constant. So I'm going to skip over causes and examples. You can read through those. Typically, there's no treatment. The patient just needs to be monitored closely. Second degree heart block. So with this, there's more P waves than QRS complexes. And the rhythm, the pattern is irregular. So you have a PR interval that increases until the QRS complex finally drops off. And then that cycle, it just repeats itself again. So if you turn the page here, you'll notice you have, if you look at this, you will see that first PR interval. And then you look at the second, and you can see it's much wider. You look at the third complex, and again, it's wider. So you could have the first PR interval, it could be 0.24. Then you're going to have 0.28, then maybe 0.30. And then you'll notice you'll have that P wave, but then the QRS complex is dropped. And that is a second degree heart block type 1. So now I'm going to move on to type 2. And so with this is an intermittent block at the level of the bundle of His or bundle branches, and it results in atrial impulses that are not conducted to the ventricles. So a photo of this, as you see here, you'll have a prolonged PR interval, and then you'll have another P wave. You see there where it was blocked. The difference with this is you do have a dropping of the QRS complex, but that PR interval does not progressively prolong. So it doesn't get wide, wider, widest. And I'm going to skip over to third degree heart block. So if you look at this, and again, I mentioned that idioventricular rhythm. It looks kind of similar to this, but with third degree heart block, you see the P waves. And so you can see how wide they are there. And that's a good photo of third degree heart block. And so with third degree heart block, you're going to be really concerned about this because the patient may need a pacemaker. And so I'm going to let you read through the description, and I'm going to start a new video, and we'll pick up with ischemia and infarcts.